Hi, this is Dr. Atropine, and today's topic is role of atropine in the control of myopia progression. And this is a review. Why this topic is necessary? Because myopia is reaching in epidemic proportions, and it has a global increase in the prevalence rates. So it is very much necessary to know about the exact cause of myopia and to treat it, because it is estimated that by 2050 almost 5 billion, which is 50% of the world population, will suffer from myopia. In East Asia it is very prevalent. It is very highly prevalent, and in the rest of the world it is also increasing, and this increase has alerted eye health experts to control the onset and delay the progression. So this is very necessary. The risk factors are some of the risk factors are identified, but the exact etiology is still unclear. And the myopic maculopathies, it is the sight-threatening complication which occurs in high myopes. So this is very necessary to find the exact cause of myopic progression. So atropine, nowadays it is the most effective medication that has been demonstrated to be consistently effective in slowing myopia progression, and it is a natural alkaloid which is extracted from the Atropa belladonna tree. Atropine is anti-muscarinic. It blocks the muscarinic receptors from the stimulation by the neurotransmitter acetylcholine. It do not undergo any chemical reaction with acetylcholine. It do not affect the release of acetylcholine, the rate of hydrolysis of acetylcholine. It does not interfere with the release of acetylcholine. So the action takes place at nerve ending without blocking the transmission of impulses. Atropine is non-selective, and it cannot distinguish between M1, M2, and M3 receptors. Atropine is absorbed mostly in the gut and is distributed widely in the body. It is metabolized in the liver and excreted in urine 60%. Atropine inhibits secretions, it reduces the tone, it relaxes the smooth muscles, it increases the heart rate, the depth and rate of respiration. In the eye, atropine is used for two things: cycloplegia and mydriasis. The mydriasis is induced by blocking contraction of the circular pupillary sphincter muscle. The circular sphincter muscle, it is normally stimulated by acetylcholine release, thereby allowing the radial iris dilator muscle to contract and dilate the pupil. While the cycloplegia is induced by paralyzing the ciliary muscle, whose action inhibits accommodation and allow the accurate refraction in children. It also helps to relieve the pain associated with iridocyclitis, and also it treats the ciliary block malignant glaucoma. But keep in mind that both these pupil dilatation and cycloplegia, they represent problematic side effects without therapeutic benefit for myopia control. Now, side effects of atropine, they are not uncommon and they cause inconvenience, but they are rarely serious. They are caused due to the facets of adsection other than for which it is being used. The toxic effects of atropine are termed as belladonna poisoning, and the severity of the symptoms vary from mild to moderate to severe, depend upon the dose and the source. The side effects are systemic and ocular. The systemic are dry mouth, difficulty in swallowing and talking, dry, flushed and hot skin, especially over the face and neck, difficulty in micturition, decreased bowel sounds, excitement, ataxia, agitated delirium, acute psychosis, hypotension, weak rapid pulse, cardiovascular failure with respiratory depression, convulsions and coma which occurs in severe poisoning. Ocular side effects are dilated pupil, dreadful visual hallucination, photophobia, accommodation paralysis, and local allergic response. Now the atropine in myopia control, the history. The optical correction and surgical correction of myopia. They only concern about the improvement in the visual acuity. But these optical and surgical correction have nothing to do with the control of myopia progression. While topical atropine in myopia control, it dates back early in history. It's starting with early studies by Bedrosian in 1960s and 70s. However, Bedrosian's studies were deficient. Particularly, his studies could not distinguish between reduction in myopia due to long-term cycloplegia and those due to reduced axial length elongation. So it questioning the conclusion that myopia progression could be controlled by a topical atropine application. Although the desired outcome was achieved by this study, but the pathological complications could not be limited. Now, to establish the efficacy of atropine in myopia control, another study was done by Katie et al. Katie et al. Also performed a retrospective study among control groups and 2 atropine groups. However, his studies Katie et al. Studies were not randomized, and also the treatment regimens varied significantly among groups. Then the first anti-myopia effect of atropine limited to duration was first studied by Gimbel. However, his study lacked control groups, and the treatment regimen were also supplemented by spectacle use. This led Gimbel's study to be deficient in utility. In 1989, Yen et al. Conducted the first randomized placebo-controlled trial of 1% atropine for myopia control. We will discuss all these again in full detail. Now, what is mechanism of action of atropine? The topical atropine has shown to delay myopia progression and axial elongation in dose-dependent manner, but till date the exact mechanism of action has not been elucidated fully. Initially, it was thought that the drug acted through accommodative mechanism. Later evidence suggests that the mechanism was through non-accommodative pathways. Although atropine causes accommodation block, atropine has been shown to increase the choroidal thickness in children. The plausible mechanism is thought to be through modulation of dopamine release, which has been correlated with a reduction in the rate of axial growth. Atropine exerts its action on the retinal hemacrine cells and dopamine when atropine binds to muscarinic acetylcholine receptor on the cells. They could release dopamine. Dopamine is considered to play a role in slowing myopia. It has also been postulated that the up and down regulation of retinal and scleral muscarinic receptors have influence on the scleral matrix. Inhibition of myopia induction has been shown in both mammalian and avian eyes. Atropine have a function at a relatively lower dose through M1 and 4 receptors. On the other hand, the non-muscarinic and a direct influence of atropine on the scleral fibroblasts could also contribute. The scleral muscarinic receptors might modulate the function of the scleral fibroblasts, interfere with the scleral remodeling that accompanies progressive myopia. Atropine could be directly acting on the sclera and might play a possible mechanism in inhibiting glycosaminoglycan production and thus eye growth. The actual mechanism may include a combination effects. but determination of the primary mechanism of action may allow more targeted therapy and alternative therapies for children who continue to demonstrate rapid myopic progression on treatment. Now the dose. Dose of topical atropine, it varies and has been administered in children in varying quantities with myopia in an attempt to prevent myopia progression. There have been a number of studies that have evaluated the relationship of concentration of atropine to the reduction of myopia progression. Studies have been performed administering high dose of atropine concentration 1% or lower than that. The efficacy of 1% atropine was studied by in these studies like Bedrosian et al., Gimbel, Gruber, Yen et al., Romano, Chiang and Fain. And nightly instillation of 1 drop of 1% atropine effectively halts the progressive increase in myopia, refractive error and also eye elongation relative to untreated eyes. However, adverse side effects including mydriasis, cycloplegia and accelerated progression on cessation called rebound effect have limited the clinical use of 1% atropine. Consequently, the interest has shifted to the use of much lower concentration, which also appear to reduce myopia progression, although in a dose-dependent manner. Management of myopia using low concentration atropine eye drops are well tolerated and with less rebound following cessation of treatment. Unlike those with high dose, Gong et al. Meta-analyzed that the efficacy of atropine is concentration independent from 0.01% to 1% atropine, whereas the adverse effects are concentration dependent. The American Academy of Ophthalmology recommends the use of 0.01% of atropine for myopia control. At present, 0.01% atropine is the most popular measure for myopia control. Now the clinical myopia control studies. So, starting with the early studies by Bedrosian in the 1960s and 1970s, there have been numerous studies of atropine topical effect on myopia progression, which includes a number of retrospective studies, prospective studies, randomized control trials. There is a long list. So, the earlier studies performed by Bedrosian, who concluded that the topical atropine could halt myopia progression but lacked enough evidence. Then Gimbel et al. Studies also pointed toward the similar conclusion, but its utility was limited to variation among treatment regimens. Then in 1989, Yen et al. Conducted the first randomized placebo-controlled trial of 1% atropine per myopia control. There was randomization of 96 children and age was from 6 to 14 years. To 1% atropine was given and 1% cyclopentolate was given, and placebo, there was a placebo group, and all the follow-up was done for 1 year. The study concluded that 1% atropine conferred the best efficacy in myopia control among the 3 studies group, with myopia progression of 1% atropine was minus 0.22 diopter per year and minus 0.8 diopter in 1% cyclopentolate group and minus 0.91 diopter per year in placebo group. The effect of atropine in axial length could not be ascertained due to unavailability of axial length data. Furthermore, a number of study dropouts were noted attributing to the side effects of atropine, mostly photophobia, among high concentration groups. Due to the demerits of high dose, interest shifted toward a much lower concentration of atropine. In 1999, a randomized control trial was conducted by Shi et al. On 200 children, on 200 children, on 0.5%, the dose was 0.5%, 0.2%, 0.25% and 0.1% atropine and 0.5% tropicamide as a control group. His study proved that all atropine treatment groups were much effective in controlling myopia progression following a 2-year treatment period with a mean myopia progression of 0.04 diopter per year in this group and 0.45 diopter in this group and 0.47 diopter in this group and minus 1.06 diopter per year in the control group. These dosage of atropine were much tolerated in comparison to previous high doses. Side effects complained with 0.5% atropine only by 22% of subjects. However, the study was limited by lack of axial length data in placebo control group. Now, to address these shortcomings, she et al. Conducted a randomized controlled trial among 227 study populations. This study compared changes in both the refractive error and axial length. In axial length of a group wearing multifocal spectacles treated daily with 0.5% atropine with those of two placebo control groups. There were two placebo control groups. Over 18-month treatment period, the atropine treated group recorded a mean increase in myopia of 0.42 diopter. This was significantly lower than the changes of 1.2 diopter and 1.4 diopter for the multifocal and single vision spectacle wearing control group respectively. A corresponding smaller increase in axial length was recorded for the atropine treated group of 0.22 versus 0.49 and 0.59 mm. It implies that the intergroup differences in myopia progression were at least partly a consequence of inhibited eye elongation. The strongest evidence for 1% atropine on myopia control was rendered by ATOM-1 study. ATOM-1 study means atropine for the treatment of childhood myopia. It was conducted by Chua et al. In 2006. It is a randomized double-blind placebo-controlled trial including 400 children, randomizing them into two groups. The treatment group receiving 1% atropine once per night in one eye and no treatment in the fellow eye, and the control group received placebo in one eye and no treatment in the fellow eye. In the results was the mean rate of myopia progression following 2-year treatment was approximately 77% in the treatment group compared with the placebo group, with myopia progression significantly lower in the 1% atropine group, 0.28 diopter per 2 years, and the control group 1.2 diopter per 2 years. The mean increase in axial remained unchanged, minus 0.02 per 2 years in the 1% atropine group, compared with significant elongation of axial length 0.38 mm per 2 years in the placebo eyes, although only 18% of the subjects complain of side effects. The safety concern of high concentration of atropine remains a question. Moreover, a rebound phenomena was observed following the cessation of atropine eye drops administration. During the 1-year washout period, the subjects of ATOM-1 study had mean myopia progression of minus 1.14 diopter per year in the atropine 1% group and minus 0.38 diopter per year in the control group. This is suggestive of myopia rebound in the atropine treatment group. By far, high concentration atropine remained the most efficacious treatment for myopia progression, but the side effects profile and rebound following drop cessation limited its widespread use. In 2012, the ATOM-2 study evaluated lower concentration per myopia progression to determine the lower optimal concentration for anti-myopia effect of atropine among 400 children. 0.5%, 0.1%, and 0.01% concentration of atropine were randomly allocated in a ratio of 2 to 1. Initially, no placebo was allocated as 0.01% of atropine was considered to be used as control group. The results were: the mean myopia progression over 2-year treatment was 0.30 diopter in 0.5% group, 0.38 diopter in 0.1% group, and 0.49 diopter in 0.01% group, and 0.49 diopter in 0.01% group. While the axial length elongation was 0.27 mm, 0.28 mm, and 0.41 mm in the 0.5, 0.1 and 0.01% atropine groups respectively. An interesting finding of ATOM-2 study was that the children in atropine 0.01% who had myopia progression by 0.43 diopter in the first year had a significantly slowed down progression during the second year, which was found to be only 0.06 diopter. However, the axial elongation was 0.24 mm during the first year, 0.17 mm during the second year, with a total of 0.41 mm increase over the 2 years. Thus, ATOM-2 study concluded the efficacy of 0.01% atropine based on decrease in mean refractive error rather than axial length elongation. Furthermore, the side effects were much less in comparison to previous high-dose studies. Interestingly, a similar rebound was seen in 0.5% and 0.1% atropine groups, but much less with 0.01%, with myopic progression in 1 year washed out to be 0.87 diopter, minus 0.68 diopter, and 0.28 diopter in atropine 0.5%, 0.1% and 0.01% groups respectively. With fewer side effects and rebound following atropine cessation, ATOM-2 study concluded that 0.01% atropine was better in treatment to side effect balance. Although the ATOM-2 study established the efficacy of low-dose atropine in control of myopia progression due to lack of placebo control group, the study was limited. Therefore, low-concentration atropine of myopia progression LAMP study was conducted, which is double-blinded randomized placebo-controlled trial to evaluate the efficacy and safety of low-concentration atropine 0.05%, 0.025%, 0.01% daily. After 1 year, the mean SE change was 0.27 diopter, 0.46 diopter, 0.59 diopter, 0.81 diopter respectively. Meanwhile, the mean axial length change after 1 year was 0.2 mm, 0.29 mm, 0.36 mm, and 0.41 mm respectively. LAMP study noted a clear concentration-dependent response. Among them, 0.05% atropine was the most effective for controlling myopia progression and axial elongation during the study period. Furthermore, 0.01% atropine reduced axial length elongation at 12% compared with placebo group, along with 27% reduction in the mean refractive error progression. The side effects were minimal and the drug was well tolerated. The LAMP study provides the strongest evidence in favor of low concentration of atropine to halt myopia progression. Furthermore, LAMP study has delineated a concentration-dependent response in both the efficacy and side effect profile in the low atropine concentration range from 0.05% to 0.01%, which previously had been a controversial issue. After Atropine LAMP study, many other studies have established the safety and efficacy of varying dose of atropine in myopia control. In meta-analysis, Hong et al. Reported the treatment effect of atropine, high, moderate, and low dose in comparison with placebo or single vision lens was strong, and in particular, high dose atropine 1% and 0.5% was significantly superior to other interventions except for moderate dose atropine 0.1% and low dose 0.01%. In a randomized control trial, SHAPE-V, here you can see SHAPE-V, a total of 220 children aged 6 to 12 years with myopia of -1 to -6 diopter in both eyes were enrolled. It was a randomized placebo-controlled double-masked study in which subjects randomly assigned in 1:1 ratio to atropine 0.01% or placebo group to administered once nightly to both eyes for 1 year. The study reported the mean myopia progression of 0.49 diopter and 0.76 diopter in the atropine 0.01% and placebo group. So this study concluded that 0.01% eye drops can slow myopia progression and axial elongation. In this study was Spanish study group of atropine treatment for myopia control GTAM. It evaluated the efficacy and safety of 0.01% eye drops per myopia control in a multicentric pediatric Spanish cohort including children aged 6 to 14 years with myopia being -2 and -6 diopter. So, and these findings concluded that atropine 0.01% is effective and safe for myopia progression. Now, how to prepare 0.01% atropine? It is very simple. Draw 0.1 ml of 1% atropine sulfate eye drop and then inject it into 10 ml bottle of either commercial artificial tear or balanced salt solution eye drop, and it can be used for 28 days after opening. You can also use normal saline based 0.01% atropine eye drop. Dilute 5 ml of atropine sulfate injection, which contains 0.6 mg per ml, with 25 ml of 0.9% sodium chloride solution to make total volume of 30 ml. Then divide it into two 15 ml bottle. Thank you very much.